Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.
My name is Dr. Jodi Edwards. I'm a scientist and director of the Brain and Heart Nexus Research Program at the University of Ottawa Heart Institute. In my lab, we use big data and data linkages to explore new markers of heart conditions such as atrial fibrillation, which increase the risk of serious brain disorders such as stroke and dementia. It's my hope that this work will improve the opportunity to detect these changes and increase prevention and treatment in individuals at risk of brain diseases.
Good morning, and thanks for tuning in to Beats Research Radio. My name is Hallie Arnott, and I'm the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student in Biomedical Engineering at the University of Ottawa. Today, we're here back at Beats Research Radio, where we're streaming live from an active lab at the University of Ottawa Heart Institute. The goal of our show is to communicate scientific research that's being conducted in labs like the one behind me to the community so that we can engage people from all different backgrounds about how science, technology, and other medical breakthroughs go from the lab and research to the clinic. Today we have Dr. Jodi Edwards sitting with us today. Dr. Edwards is a scientist and director of the Brain and Heart Nexus Research Program at the University of Ottawa Heart Institute and an affiliate investigator with the Clinical Epidemiology Research Program at the Ottawa Hospital Research Institute. Dr. Edwards has held consecutive terms as the chair of the National Training Associations for both the Canadian Stroke Network and the Canadian Partnership for Stroke Recovery, and she currently sits on the editorial board for the Journal of Alzheimer's Disease. Dr. Edwards' research program utilizes clinical and administrative data from population-based databases to evaluate the independent and cumulative contributions of unexplored cardiac risk factors, including physiological changes associated with early cardiac remodeling on clinical outcomes and individuals with a high risk of stroke, with atrial fibrillation and cognitive decline. The ultimate goal of her research is to develop predictive tools in order to identify those at the highest risk for adverse cardiovascular outcomes and extend the window that we have for preventative management in this population. So thank you very much for being with us today. I'm excited to hear a little bit about what you have to say about your research.
Well, thanks so much for having me.
Do you mind telling our listeners a little bit about your background and how you found yourself as a researcher here at the Heart Institute?
Certainly. So my first graduate degree I was at the University of Calgary, and it was actually more in neuroscience proper. I was using neuroimaging techniques, so magnetic resonance imaging, MRI, to study the brain and specifically how the brain processes language, undergoes different types of cognitive tasks, and also recovers those functions when you've had some sort of insult, like a stroke. And so that formed the basis of my graduate work, and I did some work after graduation with the neuroimaging group at the Foothills Hospital in Calgary. And then when I decided to shift into further graduate studies and do my PhD, I really sort of wanted to have a shift in focus to more applied research. So I really wanted to start addressing problems for the patient and getting that, that research into to something that was usable for patients. So that's when I chose epidemiology, and I shifted into my PhD in epidemiology at the University of British Columbia and studied there with Dr. Lara Boyd, and I did a cardiovascular focused PhD in epidemiology. And from that time, I went to Sunnybrook Hospital in Toronto after my PhD to do some postdoctoral work in the lab of Dr. Sandra Black. And there I really started to expand my focus more into not only stroke, but vascular cognitive impairment. So, the brain is joined in all these ways, and there's different trajectories. People can have a stroke, or they can start to develop cognitive decline and dementia. We started to look at the broader picture of how cardiovascular disease affects the brain. And then from that time, I was recruited and appointed here at the Heart Institute, and have since established my program and started to really delve deeper into some of these questions.
So as you were saying, neurology and cardiovascular research is very intertwined and interrelated. So do you think studying these symbiotically is really important in order to come to a more of a general conclusion for what's happening at a larger scale instead of just looking at one organ?
Absolutely. So I would say it's not only important, but it's critical, because your body is not just one system. So although we understand a lot about the heart and how the heart can impact different kinds of outcomes for patients, everything is connected, and the heart actually plays a really important role in feeding the brain and how the brain functions, and there's a lot of bidirectional connections between the heart and the brain. And so I think understanding that system as a whole is going to give us real insight into how to better manage patients and prevent and treat diseases of the cardiovascular system.
Right. So your research is also focused around developing predictive tools for identifying the high risk of adverse cardiovascular outcomes. Would you be able to tell us a little bit about what these tools are and how you come up with the tools, and where you get the data to even come up with these tools?
Yeah, well, that's been the exciting thing, I think, in the last 10, 15 years, is that we've kind of exponentially expanded the information that's available to us, and we have all of these large databases. We have data providers here in Ontario and across the country, really, in every province, but they track patients' experience every time someone's in the hospital, every time someone sees their doctor. It all gets documented, and what we can start to do then is put all these information sources together to develop these predictive tools. So when you see your doctor and you're in the clinic, the doctors, they have clinical tools that enable them to kind of make predictions about how someone might do or what treatment they might need. And they're typically focused on a set of traditional risk factors, which is obviously very important information, and you need to factor that in. But now with these databases that we have at our availability, we can start to combine information not just on traditional risk factors, but integrate all kinds of other information on genetics and blood work and the family history and the socio-demographic information. So the computing abilities that we have now enables us to make these large predictive models that can incorporate so much more information. And that really helps us to be able to start to refine our tools to say, for this particular person with this profile of characteristics, they might need something a little different in terms of treatment than someone else. And so it's getting towards a personalized approach to management and to medicine.
Right. So these risk factors that you're talking about, what are some risk factors that somebody would be looking for?
Yeah, well, certainly the heart and the brain have a lot of overlapping risk factors. So things like hypertension, which is high blood pressure, is that's a risk factor that really has an adverse effect on both the heart and the brain. As you mentioned, my work focuses a lot on something called atrial fibrillation, which is an irregular heartbeat. That's certainly something that originates in the heart, but puts people at 5 times greater risk for having a stroke, and also increases the risk for cognitive decline and dementia. So these things are very connected. Diabetes is an important risk factor as well. And of course, there's always lifestyle factors, which are the hardest to change. Things like smoking, sedentary lifestyle, obesity. All of these main risk factors are ones that contribute to both diseases of the heart and the brain.
So some of these, such as smoking, would that be, I guess it would be a little easier for a clinician to see whether or not a patient smokes or not, but do some of these risk factors rely on the patient to tell the clinician? Is there a discontinuity there a little bit?
Yeah, certain risk factors are a little bit less
Harder to
robust because they are self-reported, and sometimes people aren't as truthful or they as they might be. But obviously, the major ones are things that we can measure quantitatively. So in the clinic, we can measure your blood pressure, and we can detect atrial fibrillation on certain diagnostic tests. So those kinds of risk factors are certainly a little bit more clear cut. But of course, I think people are doing themselves a favor if they talk honestly about their whole lifestyle, and really if there's prevention of some of those lifestyle factors, the benefit is that you can have benefit for both your heart and your brain. So you get kind of more benefit for small changes.
So integrating this sort of tool into a hospital, into the clinics, is that difficult? I'm kind of changing the way a hospital functions in terms of streamlining a patient from A to B, whether or not they have a risk factor such as hypertension. Is it difficult to kind of have that tool be integrated into the hospital in order for that one patient to be able to be put from, okay, well, if they have hypertension, they might need to go here. Yeah. How does that get integrated?
Yeah, it's difficult in a couple of ways. So initially you have to develop your tool, and then you have to prove that your tool is valid for who you're saying it's valid. So there's a lot of research that goes, initially into sort of the identification of the tool and making sure that it's going to work for patients. And then there's the next step of having the uptake of the tool. So you have to have, educational programs targeted at physicians who can then want to use the tool. And also I think that our healthcare system would benefit from moving more towards a multidisciplinary care setting. So right now, if you have a tool that informs, and you just see a cardiologist, but you really have a tool that talks about both the heart and the brain, then we need to have more connection amongst the different specialties, and that tool needs to be available both to the cardiologist and the neurologist and the family doctor, who's likely going to be the person connecting most with the patient. So really, once we start to have move our systems towards more multidisciplinary care teams, I think that the use of these tools we're going to see more broader benefit.
Right. And the interdisciplinary efforts, they come even before moving into the clinic. So your role, I think, would be designing what is important for that, let's say an app, or what the system that the hospital uses, and designing the fundamentals for that. But then you would also need a computer scientist to actually go through and build what you'd like to see. So do you find that you're working already interdisciplinary beforehand?
Oh yes. I mean, I've been interdisciplinary my whole career.
Right.
So I've always had my feet in sort of several fields of study, and I think that it's actually really exciting. I think it's where a lot of the innovation happens, and I think that more and more we're moving towards being able to rely on our colleagues and work together to solve these important clinical problems.
You also have quite a difficult scenario, especially in Canada, where we have you have to look at the multicultural scenario that we have in Canada, which is important when we're designing these tools, because something that we see in Vancouver, we might not see in Halifax or in Ontario. So how do you take that into account when you're looking at these large population data sets?
Yeah, it's a really important point, and I think that it's one of the features of a more personalized approach. Not only does the underlying risk factor, that burden of those risk factors, differs from different cultures, but also the way that people access the medical system and use these predictive tools differs culturally, and also the outcomes, and so how people tend to do if they have a certain amount of disease differs amongst cultures. So it's an important characteristic to try and capture. Some of the sources of data, unfortunately, are a little bit less robust in terms of capturing cultural differences. And I think that there's work to change that and to try and integrate that more into the data. But we have tried to develop algorithms that try and kind of use things like surname and location and these general indicator variables that try and help us account for some of that information. But I think going forward, and certainly if there's any kind of prospective data collection that's going on, then culture is one of the main variables that we should be focusing on.
And do you think machine learning and artificial intelligence makes its way into that somehow?
Yeah, I think it can play a role in that. I mean, it's one of the tools at our disposal. And so I think that but it's only as good of a tool as the data that goes into it.
Exactly.
So I do think that we need better data sources that are a bit richer in cultural and valid cultural information. But then once we do have that, I think that they'll be able to integrate it and utilize it in a model and in an appropriate way.
Right. I also understand that you worked on the 2018 and 2019 Heart and Stroke Foundation stroke reports. Could you tell our listeners a little bit about what those reports are, what you would do for them, and then also how they would benefit Canadians?
Yeah, these reports are an annual report that the Heart and Stroke Foundation puts out, and they're such an important tool for the public. The last 2 years, the 2018 report focused on women's heart and brain health. So I think that was a really key campaign of theirs to try and shift the focus to the fact that women are under-researched, underdiagnosed, undertreated, and so that was a critical kind of public service message. And then actually last year's report focused on the heart and brain connection as well. So again, these are excellent resources. They're available to the public on heartandstroke.ca, and I think they provide just a really accessible, comprehensive tool for people to understand the risk factors, to look at different kinds of calculators and different ways that they can manage their risks. And I think that they're just an excellent tool for the public to be able to have a condensed source of what all the research that's going on and how people should be integrating that into their lives.
Right. So these risk factors that patients or anyone in the public can look for, once they have or they are seeing, maybe I'm at risk for this, when they go into the hospital, would they be kind of put then into that streamline for using these predictive tools, and then their information would be inputted? Are you getting feedbacks from the hospitals with the data that you're using, or is it mostly data that's from, I guess, surveys, or is it?
Yeah, no, we use multiple. So we do have survey data within the reports, but we also use from the electronic medical record. So whenever anyone sees their doctor, that information does go into their chart and it stays with their system. And then if they do end up having a hospital admission, that would come up and they would consider that, of course, in the the diagnosis and the management. And so we do use Canadian-based data for these reports and try to look at a picture of across Canada of the scope of cardiovascular disease. But also we do a lot of survey information to understand people's awareness of their risk factors and awareness of the disease. And so that's very helpful to get kind of that finger on the pulse of Canadians and how they're understanding the information. So
definitely. So the long term, how do you see your research benefiting in the long term? What's the long-term goal for what you're doing here?
Yeah, well, my main long-term goal is really prevention. So by identifying these risk markers that can tell who's at increased risk, then we can extend that window of prevention and try and get people before they end up on the stroke unit or getting into a situation of cognitive decline. And so really, I think that much of my work, the focus of it is just to make it easier for us to tell who's at increased risk and get to them earlier and increase their quality of life.
Okay, definitely. So thank you very much for tuning in with us at Beats Research Radio. Before we take a short break, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, and the Department of BMI with the Faculty of Medicine at the University of Ottawa. So thanks for tuning in, and we'll be back in a few minutes.
We realize when you come for an open heart surgery that this is met with some anxiety. It's obviously something that no one really wants to undergo. However, it is very safe. I often compare it to taking a flight across the Pacific Ocean. There's a lot of technology involved. There's a lot of standard protocols and procedures, but they're all oriented towards making this experience the safest it can be.
Once I was behind the curtains. They were very, very thorough. in explaining to me where I was going, who was in, the people that would be there. They introduced me to the surgeon. They introduced me to all the different nursing staff that would be in the room. And they made me feel at ease just by letting me know I was in their hands.
The good thing is with cardiac surgery, it has become very, very safe. We bring together the latest improvements in technology, in infrastructure, and the way that things are done towards enhancing the safety aspect and the comfort aspect for the patient and his or her family.
I needed to go into the Heart Institute to have a catheter ablation. They walked me into the cath lab. The rapport between the folks who were there, the staff that was there, you could really get a sense that they were working together. There was a lot of banter in the room. It was very comfortable. I think that 10 minutes did so much to reassure me about what was to come, probably as much as the research and the reading and the preparation I had done before.
When patients come to the Heart Institute for the first time, they'll be struck by our team approach. This is a core component in how we do things here, and we all work together with the same goal to basically provide the best care possible for our patients.
I remember the paramedic was with me, telling me, Mrs. LaBelle, you're going to the Heart Institute. When I arrived to the hospital, they told me, Mrs. LaBelle, you are having a heart attack. And I just wake up after that. I was in the recovery room. And I survived that surgery. I was alive. To me, it was a miracle.
Patients come to us after having open heart cardiac procedures. There's a team of dedicated professionals who will provide you with the expert care that you require, all of them with a specialty in critical care and in looking after patients who are the sickest in our hospital.
I was going into the unknown, and I was very scared. But I also knew the care that these individuals would offer and the skills they presented.
I have confidence. This is the right place to be at the Heart Institute.
I wouldn't be living the life that I'm living without the care that I received at the Heart Institute, and the passion and the commitment and the energy that the healthcare team brings to the care that they give you is amazing.
My name is Ben Rotstein, and I'm a scientist in the Molecular Imaging Probes and Radiochemistry Laboratory at the University of Ottawa Heart Institute. Our lab is developing new approaches to image biochemical processes, such as metabolism and inflammation, in the development of cardiovascular disorders. Our goal is to have sensitive and reliable methods to detect and diagnose these diseases before they cause significant damage. We also believe that these approaches will be useful in developing new treatments for physicians to plan interventions at an early stage.
Welcome back to Beats Research Radio. My name is Hallie Arnott, and I'm the Canadian Biomaterials Society Ottawa Student Chapter President, and I'm here today with Dr. Rothstein. He is an assistant professor with the Department of Biochemistry, Microbiology, and Immunology with the University of Ottawa, and the director of the Molecular Imaging Probes Radiochemistry Laboratory at the University of Ottawa Heart Institute. Dr. Rothstein has received Young Investigator Awards from the Society of Nuclear Medicine and Molecular Imaging, as well as the Alzheimer's Drug Discovery Foundation. He has been a co-investigator on project grants from the ADDF and the Michael J. Fox Foundation for Parkinson's disease research. The research that's conducted in his lab, the Molecular Imaging Probes and Radiochemistry Laboratory, is directed towards the discovery of radiopharmaceuticals for studying biochemical and pharmaceutical mechanisms in living systems and diagnosis of disease conditions. Specific cardiovascular imaging targets include biomarkers and therapeutic targets for atherosclerosis, arrhythmias, valve disease, and heart failure. In support of these goals, the lab also develops innovative radiochemical methodologies for small molecule radiolabeling and bioconjugation with short-lived isotopes such as carbon-11 and fluorine-18. So welcome, and thank you very much for joining us today.
Thank you for the kind introduction.
Do you mind telling our listeners a little bit about your background and how you found yourself here at the University of Ottawa Heart Institute?
Sure. Yeah, so my background is actually in chemistry. I was trained doing organic synthesis. That's what I did in my undergrad, and then for grad school, also developing methodologies. And that's really fun work. I still really love that. But I kind of transitioned from that towards applications of some of these methods. So during grad school, I was working a lot on these peptides and macrocyclization reactions. And then as part of that, I had the opportunity to do kind of an internship with a pharmaceutical company. And that was part of a collaboration with a Structural Genomics Consortium, which is a worldwide organization seeking to develop novel probes. So that kind of opened my eyes to what chemical methodologies can do. And that got me really excited to take reactions that I could develop in the lab, and that they would open up whole new spaces for us to use our chemistry to have an impact on health. So I got really excited about these types of applications, both for medicine and for other technologies. And so I decided for a postdoc to pursue one of those. And that took me into the crazy world of radiochemistry and molecular imaging. And the rest kind of just worked out in a way that I managed to secure this position and get to come back to Canada.
Oh, great. So I understand your laboratory is working on the development of the novel radio tracers to improve understanding of disease and to develop effective treatment methods and also diagnosis. Would you be able to tell us about what a radio tracer is, and then also what they do and how you are using these in order to be translational for the clinics?
Yeah, so a radio tracer can be considered just a molecule that we give at a very low dose, so that it's very safe for patients, even though there is a radioactive nuclide on there. That allows it to detect it with very high sensitivity. So we can give a very low dose of a drug to a patient or to a subject, and then we can track where that drug is going within the body and actually what it's binding to as well. So it's through a series of experiments that we're then able to determine what the molecular target of that drug is, and then we can actually quantify how much of that target is there and in what state it's in. So that lets us really study biochemistry within a living system, which is something that we can't really do by other means. So that's why this is such an important imaging modality. So these are nuclear imaging modalities. The one we work on most is called positron emission tomography. It's just a very sensitive method, and so it's used routinely for diagnosis, especially here at the Heart Institute, but also has many other applications. We can study some fundamental biochemical mechanisms within a human and complex living systems, and we can also use this to develop new therapies, as you mentioned. So for example, by measuring whether we're actually engaging a specific target that we think is going to modify disease.
So these radio tracers, would it be ingestible, or would it be through like a catheter or injectable?
Yeah, so most often they're given intravenously, but that's not always the case. So nuclear medicine has a long history going back many decades, and there's many different radio tracers that have been developed. So many are inhaled, some are given as colloids, as eye drops, and it really depends on what the target we're trying to image is. Most of the ones that we image, especially with PET, because we're working with short-lived isotopes, we tend to give them intravenously so that they engage the target very rapidly.
And you said they're very sensitive. Why are they very sensitive and able to target these locations in the body so well?
Yeah, that has to do with the physics of the system, which is that the radioactivity, it's one of the reasons we're concerned about radioactivity is because it can penetrate through materials and through your body. So that also means that as opposed to visible light or even near infrared light, that can only penetrate through maybe a few millimeters of tissue. The gamma photons that are emitted from these isotopes, they can penetrate through your body pretty easily. So that means that we're able to detect them externally. We don't need to do anything invasive, and also because whereas looking around us, we're bathed in visible light. There's much lower levels of gamma radiation in our environment. So that means that we can detect with high sensitivity when there's a photon to be detected. It really has to do with some wonderful instruments that engineers and physicists have developed throughout the 20th century, really.
Right. So a little bit about the importance of carbon-11 and fluorine-18 and how they're important for radio labeling and bioconjugation. Could you tell us a little bit about those?
Yeah, so those are kind of the two radionuclides that my lab focuses on most.
Okay.
And that's for a few reasons. The first is that they have really ideal imaging properties. So they give off relatively low energy positrons, so the radiation is fairly low energy, which gives a high resolution image. They also don't have a lot of other decay pathways that are going to cause trouble for patients in terms of the amount of radiation they're getting. And finally, there's, actually two more reasons. Another reason is that these atoms are often found in small molecules and in biomolecules, which means that most of the drugs we give, the therapeutic drugs as well as the imaging drugs, are made with these atoms involved.
Right.
That means that we can do a direct substitution, we can incorporate them, we know that they're safe, and they're going to behave in expected ways within the body. And lastly, they also have half-lives that are really convenient for clinical use. So for carbon-11, the half-life is 20 minutes, which is quite short. For fluorine-18, it's about 2 hours, 110 minutes actually. And that means that they're just long enough that we have time to make the isotope, which we do within the Heart Institute, do some chemistry to make the drug, and then we can still image it within the patient and observe the processes of the radio tracer distributing and engaging with the target we want, and then washing out. And by not having it last too long within the body, it also means the patient receives a lower dose of radiation.
Right.
So these are really nice ones for both the practical advantages and also the safety advantages of these isotopes.
So is it 20 minutes from fabrication to, I guess, ingestion or into the body?
Yeah, this is a question that a lot of people ask, and it's actually one that I remember it was one of the first questions I asked when I started getting interested in this field. And no, the case is that it doesn't have to be that way. So we can make a lot more radioactivity than we need to give in a single dose. So that means that you have many half-lives to work with. There tends to be a bit of a guideline for you want to go 3 half-lives at most for your synthesis. But very often it's just a matter of if we can make enough radioactivity and if that radioactivity is kind of high enough quality that we can safely give it to a patient at a later time point. But for example, with a lot of the fluorodeoxyglucose, which is one of the most important radiotracers in PET, it measures glucose metabolism. This radiopharmaceutical is produced centrally in many places. So for example, in Ottawa, we produce it and distribute it around the region. When we're not producing it, we actually ship it in from Hamilton every day. So they're making it early in the morning or late at night the day before, and they're able to ship it to us, and we can use it all day. So it's not a case where we're limited that much by the half-life, but when we don't have such a large operation, then yes, we want to bring the imaging and the production as close together as possible. So certainly within the same day, and if we're talking carbon-11, yeah, within a couple hours.
Okay. So how would these be different? They're both important and they're both of interest, but when would you use carbon-11 over fluorine-18?
Yeah, so that has to do with how specifically you want to label a molecule. So, for example, if we want to image, for example, acetate metabolism, which is something we do clinically at the Heart Institute as well, there's no fluorine found in that atom. It's a very small molecule, and we don't want to derivatize it because fluoroacetate happens to be toxic. So, in that case, in many cases, carbon is really a desirable isotope because it's found in so many molecules, and all organic molecules have carbon. With fluorine, definitely the practical advantages are the slightly longer half-life. So when we can incorporate that, we do like to. The chemistry can sometimes be more challenging with fluorine. So very often in my lab, we'll use carbon for early development. It's easy to get the isotope on. We can test a number of molecules, and then when we find one we like, we may try to label it with a fluorine isotope instead.
Very cool. So what do you think one of the main challenges is in the field of radiochemistry and also with radio tracer development? Is there something that is slightly more complicated or makes the process harder?
There's a lot of challenges. It's really like doing drug discovery, but it tends to happen more in academic labs. So I'd say one of the biggest challenges that a lot of labs face is finding a molecule that engages with a target very specifically within the human body. It always actually amazes me that we have any radio tracers that work well, because the number of targets, the number of things that can happen to this molecule once you give it into a living system is really innumerable. And the fact that we're able to find some that get into the body, get taken up in the right tissue, bind to the right target, and don't bind to so many other things that our entire signal is washed out is really amazing. So that's always been a major challenge. But I think more specifically, there are a lot of challenges now where we're trying to pair diagnostic radiotracers with therapeutic drugs that also have radioisotopes on them. So finding ones that are really going to work both for imaging as well as therapy, and then engaging very low density targets. So for example, with metabolic targets, with glucose metabolism, those are present on every cell. They're going to be taken up pretty widely. So that's in some way a bit of a low-hanging fruit, which isn't to say it didn't take quite a bit of development, and it is a huge achievement. But then if we want to find ways to image very low-density targets, so for example, receptors like sigma receptors that are very have low expression levels, then we need a very, very high affinity molecule, and it has to be very high affinity, very selective, and very specific to bind only to that receptor in vivo. And that to me is always the great challenge. There used to be, and I think there still are many challenges with actually getting the radionuclides onto the molecules, but that's seen a lot of attention within the last decade from many excellent labs in North America and in Europe and beyond. And so now we have a whole host of more tools, and so that lets us as chemists shift our focus from methods that get the isotopes onto the molecules onto more how do we make a really nice molecule, and what types of molecules can we use to image all sorts of different targets that we never considered before.
Right. So how do you know, so you said that it's hard to have something that's going to be very specific and bind to one thing. How do you know that you're binding to the right location or site of interest? Yeah, that's always a challenge. So there's a few paradigms that we can use. So in my lab, very often we do saturation studies. So I mentioned earlier that we give the radiotracer an extremely low dose. So this means that the occupancy of our target should be well below 5%. So what we can do then is, if it's safe to, we can dose at a higher level with a non-radioactive compound. And that will saturate out the target, and then if our radiotracer no longer binds with the same kinetics, if it doesn't get taken up into the same tissue, if it washes out much faster, then that gives us a good indication that we're binding to the right target. And you can saturate different targets that way to kind of knock off the different possibilities. Now that's an infinite approach. You could keep doing that till the cows come home, but we tend to be fairly selective about it, and that can give us a good hint. There are other strategies as well. So instead of knocking out the target, we can upregulate the target and see if binding increases. Ultimately, there's an approach in synthetic chemistry that really relates to this, which is that you can never prove that a mechanism exists. You can only disprove other mechanisms. So that's kind of what we have to do as well. There are all sorts of ways to gather evidence, but ultimately we have to just build up the strongest case we can. And it may be that there are off targets that we're not aware of, but as long as it gives us a useful signal that we can then take into the clinic, then that's something that I think is successful. In terms of the length of time it takes to create these molecules so that you can then add the carbon-11 and fluorine-18 to them, and then the injection or intravenous mechanism to put into the body, what's the timeline like in terms of starting and then when it gets to the subject or the patient?
Yeah, it's a really fun day. We have a team of radiochemists at the Heart Institute that for the clinic, they do all the support work. So they're going to prepare the day ahead. They're going to know the time of injection, and they're going to work backwards from that to set a schedule.
Okay.
So when we do it in our research studies, we tend to have a large team involved. So there's somebody in charge of making sure that the isotope is being made, bringing it up to our synthetic labs, another person in charge of synthesis, and then maybe they're also doing the analysis, making sure that it's of the right quality, we made the right thing. And at the same time, they're coordinating with people getting the research subjects ready, so whether it's animals or cells or tissue, prepping that so that we can really stick to a tight timeline, and we know that we're going to pull the study off on time. So it really does take a team effort. The best way to go is to write out your plan in advance, have good communication, have timelines and checklists, make sure everything is going to go off. There's always going to be problems, there's always going to be delays, but the more structured we can have a study and the more people we can have involved who are communicating well, then it works. So I typically for fluorine-18 one, again, you have a bit more flexibility. So if things are delayed by half an hour, even an hour, maybe you can still get the study done. But with carbon-11, you really have to be planning down
to the
like
minute?
a few minutes. Yeah.
A few minutes. Okay. And how many people would be involved in this process?
So in our lab, it's typically at least, I'd say, 3 if we're making the radiotracer.
Okay.
But they're exciting days also. So
Right.
the grad students, even if they're not directly involved in the study, they want to help out in some way. So it's really, you have to have a good team building environment, making sure everybody can work together.
That's great.
And yeah, that tends to be one of the most fun things we do. in the
Yeah,
lab as
make
well.
sure you're on time for work that day.
Yeah, and then it's not just, it doesn't end there. Once it's into the patient or into the subject, then we might be doing things like drawing small amounts of blood from them and analyzing that. And it really, it lasts all day, making sure that everything gets pulled off.
And the monitoring after the molecule and isotope are in the body, then would you monitor for a week or a day, a month?
It depends on the isotope. So for fluorine-18 and carbon-11, we tend to image for an hour, maybe a little bit more than an hour, a couple hours. There are longer-lived isotopes. So there's zirconium-89, which has a half-life of just over 3 days. So for that one, yeah, you can image out for a week or maybe a little bit longer as well.
Okay.
So again, like based on what applications you're looking at, you may want a longer-lived isotope. And then it's just a matter of that's going to come along with higher dosimetry, but that may be fine depending on the population you're looking at.
And monitoring the possible adverse effects of this, would be part of what you do, or would that be something down the road? Or
So there are radiobiologists who specialize in this. It tends to be that we know the levels we're working with are pretty safe. But certainly we do monitor and make sure that everybody's recovering well. We're actually with small animal studies, we're more concerned about anesthesia than we are with the radiation dose. So it can be a stressful experience for them if that's the case. But the radiation itself, we've never seen adverse effects in our lab, and very rarely will you hear about that from an imaging study.
Okay, that's good. And so these tools that you're developing, they're extremely translational in terms of what you're doing in the lab and how that can be used in the clinics. Is there, do you think about, it's important to think about how what you're developing is going to be translated. So do you find you're really working right off the bat towards that translational ability of your molecules and your radiotracers?
Yeah, absolutely. And not every project is aimed towards clinical imaging, but I'd say that really is where we should be aiming, because that's really the strength of this technology. That's what nuclear imaging and PET can do better than anything else. So for that, we're really fortunate to have engaged clinicians at the Heart Institute, and I think that's essential for anywhere you go. Building those connections and having good relationships with people who tell you what they need in the clinic, and then on the other side, also the biologists, so you know that you're going after a target that's appropriate. So that's actually one of the things I find most gratifying about working in this field, is that I know my role is as the chemist, I'm leading development of radiotracers, but I'm working very closely with physicists. I'm working very closely with clinicians. I'm working with biologists. technologies. It's a really team effort, and it's really gratifying to be able to be that helpful to other people and also learn what they do.
That's very cool. So do you find your research then is extremely interdisciplinary, and you're working with clinicians and biologists and chemists?
Yeah, almost too much so, where I like to bring chemists into my lab because I know how to train them, and I think that they can do some really hard stuff that we need. And inevitably, it seems like the chemists want to go and learn biology. They want to go learn physics as well. It can be really tempting to go and try to do everything, which is fun. And it's important that we understand each other, that we're able to communicate on the same levels and really work together that way. But it's also important for us to specialize and do our thing very, very well. So there's a balance that has to be struck there.
And so just briefly, a final question. What's the long-term goal of your research? Is it to push these radio tracers into the clinic?
Yeah, absolutely. And I think that's what I measure myself by is I know that the research I do is very resource intensive, and it's very, it has a lot of potential to help people. So we have to find a way to deliver on that potential. So ultimately, I mean, there are a lot of things we do that are not aimed at clinical translation, and they're still exciting, they're still fun, and we still think they're very important. But ultimately, we know that we have the opportunity to really have a positive impact on human health, and so that's what we have to aim for the entire time.
Okay, well, perfect. Thank you very much for teaching me and our listeners about radio tracers. Thank you to everyone today for tuning in to Beats Research Radio. Before we go, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, the Beats Research Lab, and the Department of BMI in the Faculty of Medicine. So we're signing off now, and we'll see you next week.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.